Good afternoon, everybody. Thanks for taking the time to join us this afternoon. We will try to keep this brief in the interest of time and share with you our ATOP updates as well as some recent information we've been given from CMS, go over some billing questions, and present a clinical case that we thought was really fascinating and that people would benefit from hearing about. As well as share a little bit of the results from the most recent RTI Year 3 annual report. So we'll go ahead and get started. Christina, if you could advance the slide for me. Keep going. So first, we're going to just share some progress with everyone. Now that Year 3 officially ended with the close of the third quarter of last year, we are officially in the final year of the program. And so far through November of 2019, which is when we received the most recent claims count data report from CMS, we have a total of 1,293 claims billed for a total of $1.8 million in additional revenue for Nevada's nursing facilities. Colorado, just for comparison's sake, is a little bit below that, but you guys should be happy about that because there are a lot more facilities in Colorado participating, 21 compared to the 13 in Nevada. So you guys are knocking it out of the park in being able to convert your changes in condition episodes into paid claims. The total amount between the two states is a little over $3.6 million. So that's a huge boost in revenue and a thank you for participation in this project over the past 8 years. Next slide, please. This is just a breakdown of all the facilities and where they sit in terms of total revenue dollars. So the facility at the top, which is titled Home 2, we blind them and we're happy to share, or you probably already know based on your dollar amounts, who you are and where you sit in this list. But they start with the highest revenue earners at the top and then go down to the 13th facility at the bottom. You can see in most cases that the dollar amounts correspond with the number of eligible resident counts, right? That makes a huge difference. A lot of folks don't have a lot of eligible residents for a variety of reasons. That could be managed care creeping in or just a smaller facility. But there's been lots of good revenue earning over the past, almost 3.5 years now since we've started in December of 2016. And if you would like to know specifically where you sit in this list, just feel free to chat us and we will get back to you and let you know. Next slide, please. So the other thing I want to share is the RTI Year 3 annual report. We received this report at the end of December, and we took some time to have our data analyst go through this. As you can imagine, it's a lengthy report with lots of addendums and attachments and detailed. And so what we wanted to do was make sure we went through it so we could glean out of it the most important things in the report and what it means to you and the work that you guys are doing in your facilities. So Year 3 is actually an analysis and evaluation of Year 2 program, right? So we're looking at the results from October 2017 to September of 2018, which is Year 2 of the program. We've completed Year 3 and now we're in Year 4, the final year. However, it takes a long time for RTI to gather all the administrative data and do the comparative analysis to the national comparison group. So the reports run late for us. We're probably not going to know completely how we did through all 4 years of the program until the end of 2021, maybe the beginning of 22. But what I'd like to share with you today is just some overall brief results so that you get an idea of where we stand. So Nevada has seen reductions in hospital utilization. None of it's been statistically significant in this year. We have seen reductions in all-cause hospitalizations, about 5%, and also in 6-condition ED visits, large, about almost 30%. That was one of the biggest reductions we saw. We also saw reductions in all-cause expenditures for hospitalizations. almost 16%, and also in total Medicare expenditures. Very slight, just under 1%, but still reduction. The important thing about this is that even though there have been some relatively big increases, and some of those increases have been significant for some outcomes, we look to be holding the gains we made in phase 1 overall. And that will become a little more clear when I show you some graphs that compare us to the national comparison group and all of the other programs across the country that are also participating in the same nursing facility initiative that you are. It's also important because in general, Nevada is a high utilization state. We have one of the highest Medicare hospital readmission and admission rates in the country. But the fact that the ATOP facilities have maintained hospital transfer rates well below the national comparison group is a lot to be excited about and to know that we've been successful in. We have seen some statistically significant increases, mostly in potentially avoidable hospitalizations, pretty large utilization, and also in expenditures for potentially avoidable hospitalizations. We have seen more of our decreases that are focused more directly on 6th condition, which makes sense because in phase 2, that's what we put all of our focus and attention on, right? So it makes sense to us that we are not seeing overall reductions in potentially avoidable hospitalizations. If you recall, that can be, the 22 diagnosis codes that they include under that definition, but we're seeing better results more in the reductions for 6 conditions and primarily around transfers to EDs, right? So folks that went to the ED maybe with a pneumonia and then didn't get admitted, we've had a lot of reductions in that. You guys are having good results in keeping those folks in the residence and treating them, and that has resulted in the claims that you've been able to bill for the program. Next slide, please. So here, I'm going to try to break this down, and you guys are going to get copies of this PowerPoint, and we're going to record it, so you can spend some more time looking at it. But basically what this is saying, this is Nevada, this is not Colorado. I have separate slides on that. I'll show you guys how Colorado is doing briefly, just out of interest. But in Nevada, we are the orange line. That is the ATOP clinical intervention plus payment reform group. The light blue line is all of the other nursing facilities in states like New York and Indiana and Missouri and Alabama and Indiana and Pittsburgh that are participating in the same program we are. They're the light blue line. And then the dark blue line is the national comparison group. All of those other would-be ATOP eligible residents across the country that are in states that are not participating in the initiative, that were put through a rigorous demographic, I want to describe it as if they put it through a funnel, right? So they could get them to match up as closely as possible to what it would be to be an ATOP eligible resident and then compare it. So when you look at where the orange line sits in comparison to the blue line, we're only really close in all-cause hospitalizations, right? In that first graph up in the upper left-hand corner. And then when you look at ED visits, we're well below. And then if you go down to the next layer, which is the potentially avoidable hospital transfers, we're well below that national comparison group. And we're also below it for ED visits that are deemed potentially avoidable. And then the next layer of that is the 6 conditions, right? So that national comparison group is a little bit higher, and we're well below the national comparison group, again, in terms of 6 condition transfers for hospitalizations and ED visits. And in some cases, we're even better than all of our other states that are doing the same program across the country, right? We seem to be doing really well in decreasing 6 condition hospital transfers, better than everyone else. In the most case, we're really kind of along the same line as everybody else, but well below that national comparison group. What we really want to see, and what we know CMS is working on, is giving us data that predates when ATOP started, right? So all of these numbers start in 2014. Their comparisons go from 2014 to 2018. What we want to see is 2011, 2012, 2013, before phase 1 started and right when it started, to see if there were ever points where we matched up perfectly with the national comparison group, because it'll give us a better analysis of how much we were able to contribute to those reductions over time. And that is something that the RTI, the national reviewers, are looking at, but we probably won't see until we get the final report in a couple years, unfortunately. So because of that, go to the next slide, please. Oh, quickly, I'll just talk about Colorado and then I'll show you. So Colorado's doing better, right? Colorado is the payment-only group. There's 21 facilities. They don't bill as much as we do, but they have seen statistically significant reductions in hospital utilization for 6-condition ED visits, big numbers, almost 38%. Medicare expenditures for potentially avoidable and 6-condition, almost 42% and 51% for ED visits. We do see some consistent reductions in both potentially avoidable and 6-condition, and only one other payment group across the country has seen that, right? So not a lot of folks see that in any of the other groups that are only doing payment, meaning they don't have clinical staff like you guys do. That's the difference between the two groups, if you recall. What's interesting, though, is Colorado has seen a statistically significant increase in total Medicare expenditures. So 13%. Remember, we decreased that by nearly 1%. Theirs increased by 13%. So the folks that are going to the hospital for them are costing a lot more money. They're sicker at the end of life. That's some of what we're seeing. Next slide, please. So again, this just shows you in graph form how Colorado's doing. So Colorado is the orange line again. And as you can see, the big difference here is, while again, the orange line, Colorado, is far below the national comparison group, which is the blue lines in all categories, Colorado is also pretty much far below the other ECCP payment-only groups, especially when it comes to hospitalizations, 6-condition, potentially avoidable, and all-cause. When it comes to ED visits, they're a little more closely aligned, but they really are doing a great job of keeping people out of the hospital, whether it falls into one of those 3 categories. Next slide, please. So what we're trying to do to get a better feel for projection of where we think year 3 is going to end up, and then we're doing the same for year 4. And this is what you're going to start to see. We once again revise the quarterly reports that we give you, so we can include the potentially avoidable hospitalization numbers from CMS and the all-cause hospital transfer numbers from CMS. So these 2 graphs are data that come directly from CMS when we get the claims count reports each month, which also tells us how many claims that you guys billed. This is a comparison between years 2 and years 3 only, because we didn't start getting this data until year 2 of the program from CMS. So if you look at program year 2, the first graph is all-cause hospitalizations. The rate was about 2. In year 3, unfortunately, we increased. So we were hovering around a flat rate of just about 2, and then we jumped up to a rate of 2.47. And a lot of that had to do with a lot of increases we saw in starting in Q1 of 2019. That continued into Q2, and we've talked about that at all of the meetings that we've gone to, right? We've talked about the fact that we all saw a jump in pneumonia and COPD exacerbation, hospital transfers during the flu season last year. And it should come as no surprise to us, because it was one of the worst flu seasons in decades. And now we're in a flu season right now, which the CDC has predicted is going to be even worse. So we think that that's what's contributing to these numbers in the graphs. So we've seen an increase from year 2 to year 3, which is not what we were hoping for, but we don't think that that has a lot to do with the program and has more to do with outside factors. When you look at the second graph, this narrows it down again to just the potentially avoidable hospitalizations. So the first graph on the top is all the reasons they go. The second graph is the potentially avoidables. These numbers also come from CMS. So if you look at year 2, we have an overall flat rate of about 0.62. And we saw dips and we saw some spikes, but we ended year 2 in the third quarter of 2018 pretty low, right? And then in program year 3, we spiked back up. So we went from a 0.62 overall rate to a 0.81 overall rate. And again, that had a lot to do with the spikes that we were seeing that started in Q1 of 2019, but really went to Q2 of 2019 and seemed to stay the same in Q3. The next slide is our data that's put into the web portal. Christina, can you go to the next slide? This one is the web portal data. So this is all of the data for the 6 condition hospital transfers that your clinical teams on the ATOP program are working with you on. So this, we have data from the beginning of the program. We have year 1, we have year 2, we have year 3. So you can see again in year 1, 2016 Q4 when we started, it was pretty low. We saw some spikes and we started to climb back down by the end of the year. And then our overall rate was 0.55 in year 1. And then in year 2, it decreased. We went down to 0.44. So we were able to lower the rate even further for the 6 condition hospital transfers, which is what we saw in the RTI data that I just showed you, primarily in ED visits, right? It wasn't the hospitalizations that were decreasing in year 2, but it was those ED visits that you guys were able to avoid. And then unfortunately in year 3, we spiked. We've already talked about the spike. It started happening in Q1. For us, the 6 condition spike happened in Q1 of 2019 and then immediately started to go down in Q2 and Q3 when we ended up the year. So while we started in year 1 at a rate of 0.55 and then we managed to drop it down to 0.44, we spiked back up. Not quite as high as year 1, but we spiked back up to 0.52. So what this tells us is that we saw a 20% relative reduction from year 1 to year 2, but then we saw an increase when we went from year 2 to year 3. So we have like a net reduction of about 2%, essentially. So unfortunately, there's no clear evidence for a consistent pattern of reduction in utilization or expenditures. But that's not just for Nevada or Colorado, that's across the country, right? Nobody's seeing consistency in these results in year 1 and year 2. And based on what we're seeing in our own data, we don't expect much of a difference in year 3 and year 4. But that doesn't mean that it hasn't had great impact and it hasn't been a success overall. It has been, because you guys have contributed to keeping folks out of the hospital. And one of those things that you really can't monitor, and it's qualitative, and there aren't numbers to back it up, is the lives that you've touched, some in small ways, some in really profound ways, and the differences that you've made in these people's lives, these residents' lives, and to improve the care and communication and documentation in your facilities. Any questions about any of the data? I know it's a lot to absorb in a short period of time. And I'm somebody who has to sit with it. I can't just see it and be talked to in a webinar for 15 minutes. I need time to review it, and we will give you guys that opportunity. I'll be coming back out to visit all your facilities in the month of March, and I'm happy to have long discussions about this at that time. But if you have any questions, you can pop them into chat as we're talking, or feel free to take yourselves off mute and ask your questions. Either way. But in the interest of time, I'll move forward so that we don't keep you any longer than we have to. Okay, sound good? Thumbs up? Okay. Next slide, please. I'm gonna skip the Colorado slides because it pretty much says the same thing that the RTI slides did. Go ahead, Christina. Just get us to the next. There we go. So the other thing we always talk about when we're together is our CIC audits, right? So you guys, most all of you at this point in Nevada have been through an annual audit by CMS, right? That's over. Woo! But we still audit you, right? Because we want to make sure things are going right, and then that you guys are billing appropriately, and so that if for any reason somebody comes back to audit you, you're never going to have to give money back again. That's the #1 goal. So we do quarterly audits. Our staff handles those. They work in conjunction with you, and it's those self-audit forms that we encourage you to use for all of your changes and conditions that we use to review these. So the last time we did it was in January for October through December of last year, and 93% of the qualifying CICs met criteria for ATOP2. That's huge. That's awesome work, you guys. A few of them didn't meet, and they were for minor reasons that we reviewed, and we talked to those facilities, and they were able to withdraw and then resubmit those claims. The previous quarter audit was 95%, so you're pretty much equal to what we expect. And the average over all of the audits since we started doing this a couple of years ago is 92%. So you guys have done a great job and learned a lot as time has gone on, and that's excellent improvement. We don't expect it to get any better. We just think you should just power on and keep doing great work. The next audit that we do is the SBAR audit. Next slide, please. So we also, as you know, started auditing your SBAR structured tool use. We did it for October to December of 2019 and found that 70% of all CICs, not just the ones that you build, all CICs, had a corresponding SBAR or a structured tool that you use in your EMR. This is huge. We set a goal at 80% just to set a goal, but really anywhere between 70 and 80% is really, really good, we think, because some cases it's just not appropriate to use them. You know, if the practitioners are in the facility, you're having a conversation with them, you're not going to fill out an SBAR. So they're not going to use it every single time. That's not to say that every facility in Nevada has great SBAR use. That is not true. The previous audit was 70%, so we're staying status quo. There's 8 nursing facilities in Nevada that are performing above the 70% mark and 5 that are below it. So we're going to be working more closely with the 5 facilities because we really do believe in the Interact tools. We do think that SBARs and structured tools are going to help communication between your nursing staff and your practitioners to improve the care for your residents. So we're going to keep hammering at this until the end of the program. The good news is that your average percent completed since we started measuring is 74%. It's dropped off a little bit, but it dropped off primarily because before, I think the last 6 months ago, I was only looking at the claims that you were billing to make sure that there was a corresponding SBAR or structured tool. Now I'm looking at all of them. So the fact that your numbers are that high, and I'm looking at every single change in condition, some of you have 30, 40 changes in conditions in a month. And if our numbers are still that high, that means that's really, really great SBAR use. So we'll share with you when we see you in March what your individual facility numbers were. Next slide, please. So the one thing we talk about all the time is practitioner engagement. Aren't you guys sick of talking about practitioner engagement at this point, right? It's the one, I really feel like now it's the one thing that has still held us back into really making the program sing and making sure that you guys don't miss opportunities. Next slide. So we just wanted to share some things that we think are contributing to this and talk again about what we think can be done. And then ask you guys questions if you think that we're on track or there are other things that contribute to this, or if you have other ideas or things that have worked in your facilities to help reduce the number of missed opportunities. So in both states, Nevada and Colorado, there are a total of 2,537 claims for the 6 condition codes, paid claims. There are only 984 practitioner claims that correspond to those paid claims for nursing facilities. That means that only 39% of your claims have a corresponding practitioner claim, meaning they're not billing. Why aren't they billing? They don't know if the resident is eligible at the time of the assessment, right? That we've been hearing that from practitioners. I don't know if they're ATOP eligible. How am I supposed to know? And so they just don't do it. They don't report it back. The G9685 code, which is the code the practitioners use, it's not entered or it's not reported to the biller, right? That is actually billing. In one case, there's a practitioner group in town that we talked to the practice manager recently, and they said, oh, the practitioners are required to enter the code when they put their notes into our system. And if they don't enter that code, then it doesn't get billed, right? So the practitioners are not entering the code. Well, that's an easy fix if we had known that that's how it was working. And then there's also practitioner burden and competing priorities. We all know that it was the dollar amount was not large enough to really get the practitioners to embrace this. It equalized the payment between seeing them in the hospital and seeing them in the facility. And I think for the most part, the practitioners that are taking advantage of the billing are seeing good benefits, but mostly they're just doing it for you guys, right? In some facilities, you've had a lot of really good response from your practitioners to ensure that you're able to bill. But in a lot of cases, that is the ATOP eligible, the ATOP APRNs that are doing that work for your practitioners. Bottom line. So you might have noticed in the most recent nursing facility report, we added a line for your billable claims for a month that said who confirmed it. Because we wanted you to see if we were at facility X, and I can see Patty on the screen, so I'm going to use our APRN, Patty Polina, to say that if there were 11 claims that are billable in that month and Patty saw 8 of them, that means that your practitioners are really not picking up the slack, right? And so what we want to try to do is to convert that and make sure that that communication gap is closing, and that we're not, in these last 7 months of the program, not relying so heavily on the ATOP APRNs and getting your practitioners in the habit. Not the money isn't motivating them to do it, but what should motivate them is better, more timely care for your residents, right? That keeping people out of the hospital benefits everyone, right? It benefits the residents, it benefits the facilities, and it benefits the practitioners. So we're really going to try to focus on that over these next 7 months. Next slide, please. So what this does is lead to misbilling opportunities. Either the practitioner doesn't see them within the required window of time, there's no real follow-up mechanism in place at your facilities to ensure that these practitioners are coming in, or your follow-up mechanism is to say, hey, Beth at MPR, can you have Sam see the resident, right? And then the ATOP APRNs are coming in, or Yemi at Marquis Centennial Hills or Silver Ridge, or Jean up in the north at any of the 6 facilities up there, except for Elko, because that's too far away, 4 hours away. Jean can't drive there to confirm. But Elko does a great job, and they have staff on site all the time. That's what makes a huge difference. The other problem isn't just them not being able to come in within that window of time. It's also that they're not documenting appropriately, right? Either the notes aren't there, or they did notes, but they didn't confirm the 6 condition diagnosis. They used the wrong word. And then there's no follow-up mechanism in place to review those notes and make sure that, say, hey, practitioner X, I know you know that was pneumonia. I know you're treating pneumonia, but you didn't actually say pneumonia in your notes. Can you please amend your note? But there's no mechanism in your facilities to do that follow-up work. So we highly recommend, if you haven't already done so, to create follow-up mechanisms to ensure timely confirmations and to ensure that the documentation is appropriate so that you guys can bill. And in Nevada, like I said previously, it's the ATOP APRNs that are confirming the majority of the CICs eligible for billing. So I'm going to stop for a second and ask if anyone feels like, are these the things that you're struggling with? Confirm. Feel free to take yourself off mute. I see some shaking heads, yes, that, yeah, these are the things that are contributing to it. Is there anything that anybody's done recently to help try to limit the lack of your own practitioner's involvement in ensuring that you're able to bill? Have you had any successes with getting practitioners in? Don't be shy. Even the smallest success is a huge success, especially when it comes to practitioner engagement. Oh, come on. Somebody's had success, no? Well, I know you have, because I've seen it in some of your facilities. But I won't pick on you, because that hardly seems fair. All right. I'm going to move on since I don't have any comments from the gallery. Next slide, please. So what we just wanted to point out was we created this ATOP communicating a change in condition flow chart that we gave you. It's laminated. It's probably sitting in a binder somewhere in your facility, right? And I'm not going to spend a lot of time on the first two slides because I think you guys have this part down, right? I know there's a change in condition, you know how to communicate it, and you're notifying nursing staff and moving on to the next step, which is filling out an Interact tool. Either it's stop and watch or notifying someone at your facility that something needs to happen. Next slide. And then the nursing staff is walking in, looking at that 6 conditions pocket guide, filling out an S-bar, and communicating with the practitioner to get the ball rolling, to ensure that someone's going to come in and see them, that the right tests are ordered to confirm the diagnosis, and that next steps are started. Next slide, please. So what the most important piece is the follow-up piece within that 24 and 48 hours, right? So we all know we have a 3-day window. The CIC starts on day 1, right? And then we need someone you contact the practitioner, say it's a UTI, you get a UNA and CNS ordered. Maybe they start on antibiotics, maybe they don't. They shouldn't, antibiotic stewardship, but maybe they do, maybe they don't. It's different in every facility. But really the piece that's missing is, did the provider come in to perform that in-person assessment within 72 hours? If they did, great, move on. Was it all documented? Excellent. If not, who is following up to ensure that they come in? Who, on a daily basis, I know a lot of you at your stand-up meetings are talking about this at the stand-up meeting. We have an ATOP eligible resident. They had a change in condition yesterday. We called the practitioner. No one came in yesterday. We still need them to come in. And then if they didn't come in on day 2, you're talking about it again on day 3. And really making sure that you're involving either, especially as champions, which is who is primarily on this call, either your unit manager or your charge nurses or your RCMs to help you with that process, right? Because you can't do everything as the ATOP champion, but what you can do is get a team together that's going to help close that gap. And that's really what we're focused on, is getting that team together that's going to help you close that gap. So we really want you to pull these out, dust them off, and we're going to work on these next 7 months on getting those practitioners in a timely manner and making sure that their documentation is up to snuff so that we can really get good results as we end the program. Next slide, please. So next up, we have a clinical case presentation brought to us by one of our amazing ATOP APRNs, Samantha Garr. And she is going to talk about this from her perspective. It is happened at one of her facilities. It's a great example of what happens when your code status is not addressed. And we think it is really, really important for us to talk about this, especially as we wrap up the program and talk about future work that we're hoping to do with you all and your facilities. Sam, I will let you take it away. Sam, we can't hear you. You're off mute, but we're not hearing anything. You have to know there's always going to be a technical glitch, right, for the clinical case presentation. Christina, perhaps you can pop. No, she's coming out. Never mind, no popping.
Yeah. Sounds like she might be going to one of our offices.
Yeah, while she comes to us, why don't you speed forward to the billing questions real quick? And I'll do those so we don't lose time. Okay, so I'm going to go through the billing questions really quick, and then we'll back up and go through the clinical case presentation. Okay. So we had a couple of recent billing questions and that we just wanted to share with everyone. These are pneumonia and UTI related because that's all we're really seeing at this point. That's the majority. There has been a run on some fluid and electrolyte disorders lately and a couple skin infections, but primarily you guys are still really confirming and billing for UTIs and pneumonias. So scenario 1 is change of condition for pneumonia. The chest x-ray stated that it was suspicious for pneumonia. There were no other documentation of other symptoms by the nursing staff. The practitioner did come in within 1 day and confirm pneumonia and treat for pneumonia. So the question was this billable? We put some information in here, which we'll share this PowerPoint with you, about the criteria, and that if the chest X-ray does not provide adequate confirmation, a resident can still qualify by meeting 2 of the other 4 criteria that are listed in the pocket guide, right? So that was the question. If the chest X-ray was not conclusive, what do we need to do? So we know we need to have 2 other of the 4 criteria in order to confirm it. So in our experience, you can get that from the practitioners that confirm a diagnosis of pneumonia. They also usually assess evidence of other qualifying symptoms, whether that's a fever, low O2 sat, or abnormal lung sounds. So it doesn't mean that you can't bill it. It means that we have to go dig into the medical record to find evidence of the other criteria to meet that. So the chest X-ray needs to provide definitive results. If it doesn't, we're going to look for other criteria to meet that. Does that make sense to everybody? Does anybody have any questions about that? It's pretty straightforward. It's come up recently a couple times. And if the nursing documentation isn't there to support it, the practitioner documentation can fulfill that requirement. You just have to dig in and find what we need in order to confirm that one and bill it. Next slide. So the other one is UTI, and the UTIs, I think now after, almost 4 years, we've got that down. It's presumptive UTIs that cause issues, right? Now, we talked about this when they changed the clinical criteria guidelines a while ago, was that you could bill for presumptive UTIs, right? Because primarily you don't get the culture results until maybe 3 days, maybe 4 days after you sent the testing out, right? And so in this instance, according to a provider's visit note, a patient had complaints of dysuria and frequency, and they ordered a UA. Okay, so the initial report was positive and the culture was pending. During this time, no entries were made by nursing staff to demonstrate any kind of enhanced care, and the culture came back for less than 100,000 organisms. Can we bill this for a presumptive UTI? Okay, so we know we can bill presumptive UTIs. A couple of things have to happen. Practitioner still has to come in and confirm it, right? Even if you don't have the results yet. There has to be that visit within those 3 days. Preferably. You do have a 4th day, but in this instance, really going to be only 3 days to bill for presumptive UTIs. What you have to have, though, is documentation that there was some intervention, something being done, some treatment, right? You can't just have a presumptive UTI and we were waiting on the results, but nothing was done. And yes, they came in and confirmed it. So what we want to see is that the nursing staff has encouraged fluids, right? Whatever treatment that they provided during that time period, that's what we need there. So the guidelines for presumptive UTIs are monitoring and management of symptoms need to be documented while we're waiting for those final culture results. So we just wanted to remind everybody that presumptive UTIs are fine to do, but there has to be documentation of monitoring and management of symptoms during that time period by the nursing notes. And you still have to have that in-person confirmation in order to bill it. And then of course, the day you get the results back and it says it didn't meet the requirements, you don't bill that day. So usually your presumptive UTIs, you're only going to be able to bill 2 to 3 days. Primarily. Sometimes it comes back on the 4th day, sometimes the 3rd day. That's where the timing ends. Does that make sense? Anybody have any questions about that one? We'll send this out too so you guys can read it. And now I've gotten Sam in the room and I'm going to back it up and let her take over to talk about the clinical case presentation. Do you want to be on video? Do you want me to video you?
No, it's okay.
Okay. Come over here. There you go.
Hello. Easier.
All right. Hi, everybody. We had a resident, he was 73 years old, lived in the nursing home for this particular nursing home for a couple of years. And he had a laundry list of diagnoses: CHF, ESRD, diabetes, COPD, AFib, GERD, BPH, constipation, hypotension, on and on and on. Do they have a chance to look at this case too? Do they see it? Oh, they do. Yeah, it does. So I don't have to read it to you.
No.
And he goes to dialysis 3 times a week. He was actually going to dialysis even before he transferred to this particular nursing home. So the first year he lived there, he went out 2 or 3 times. The last year he lived there, he had 18 CICs and he had 12 transfers. Because of his COPD and pneumonias and UTIs, he had a Foley for a bladder that wouldn't work, you know, due to the diabetes. So he went out a lot, but most of them, 2/3 of them, were for chest pain and SOB. Some of them were directly from the dialysis center during dialysis, and the others were after, the day after, when he had come back to the facility, and he complained of chest pain. So when he came back, they were always CHF exacerbations or fluid volume overloads. An occasional pneumonia or UTI was a secondary diagnosis. So, you know, 12 transfers is a lot, and we're just wondering what you think about this. Do you think they were avoidable? Could you do something to avoid further transfers for the chest pain and the SOB during and after the dialysis? And are you concerned about his code status? Because as it says, he is a full code, he was never married, he doesn't have a diagnosis of dementia, he's with it.
Next slide.
And he makes his own decisions. Next slide, please. So any comments? Anyone have any thoughts about this? I see a couple of you are not.
This is Patty. Bianna was saying.
This is Jean.
Okay, well, there's a couple of us.
Hey, Jean, Jean, we're having a hard time hearing you, and somebody had already taken themselves off mute. Okay.
So go ahead, Patty.
Well, Bianna was saying that about working with the dialysis center. That was her suggestion because she's wondering what was happening there.
That's a great idea.
Comment.
Jean, maybe you can type it in the chat because that was very strange. We couldn't hear you.
Yeah, Jean, we can't hear you at all. There's a weird echo, and there's something wrong with your connection.
Yeah, it's like you're playing ukulele.
Bad internet connection.
Yeah. Okay. Anyone else have anything? Any concerns? You think he should be a full code at age 73 if he's going out this many times and he's got so many diseases?
This is Patty. Do you want so I can let somebody else talk, or I can talk?
No, go ahead.
Poor Jean's trying to talk. Is she able to chat? But anyway, I mean, there certainly could be a conversation for the wishes of this patient. It's really up to where he is in the disease trajectory too. It's suspicious that he's going to the hospital so often, but a conversation could be had about what his wishes are for his continued care and what his goals are.
Great.
And then go from that to code status.
Okay. All right. So let me just give you a few comments then, okay? Because I was lucky enough to have a nurse review his chart for me. There were 65 pages of reports from the dialysis center, and there were a few things we found. Anyone who has a diagnosis of CHF should be having their daily weights and maybe a fluid volume restriction. He did have a fluid volume restriction. It was never documented. The dialysis facility was not able to get his dry weight down. You know, the nephrologist writes a prescription about how much weight he wants, how much fluid he wants drawn off. And they're supposed to weigh the person when they come back to see, did they lose that 3 pounds? Did they lose that 5 pounds, whatever? And he was never weighed at the facility. So he had gained sometimes as much as 11 pounds So that was something. We want to make sure that he's not taking in more fluids than he's supposed to, that there should have been a nephrologist consult. If he keeps coming back with a fluid volume overload, chest pain, maybe they need to have a meeting. So a whole interdisciplinary team meeting would have been good. So takeaway points. Remember, if somebody has chest pain and they're in our program, we have an EKG project working where anyone can get an EKG within 2 hours and have it read to make sure it's not something cardiac. So he could have had EKGs ordered. All our facilities have that ability. It was part of ATOP2. We should be doing daily weights. We should review the weight after dialysis. And they need to intervene depending on the facility. Like Marquis, it's like 3 pounds in 2 days or 4 pounds in 3 days as a weight gain for their CHF residents. And then they do an intervention. Monitor his fluid, do a nutritional consult. Social services should talk to him. Maybe he was having problems with the dialysis, didn't want to do it anymore. Maybe he was anxious, and they should have a face-to-face meeting. So I'm just going to go, I don't know if I can, video. Okay, so I just want to show you a couple of things. This is a list of 67 pages long on dialyzable drugs. So it turns out that he does have anxiety. He did have a prescription for Valium, and that does not dialyze out. So if he's having chest pain and it's anxiety, possibly Valium beforehand could have been something they could have done. And here's an article from JASN Nephrology Journal about using anti-anxiety meds in patients with dialysis, because they have a lot of it, and I never knew that before this. I think that's it. Thank you so much.
Thanks,
Back
Sam.
to Amy.
That was awesome. Thank you.
Thank you.
All right. See, even with technological
Jean-
issues, we can
Jean
still-
had, I'm sorry, Jean had a comment in chat.
Oh, okay, good. Let me address that.
I'm still here.
For the code status, it is up to the resident. Yeah, no, for sure.
Nobody asked.
Great.
Something to be addressed.
Yep.
Thanks.
Okay, so finally, so we don't keep you guys much past our time, we have some updates to share from CMS. Jean, in the interest of time, we can't hear you when you are taking yourselves off mute. If you could put them into chat, if we have time at the end, I will go back at the end. I would appreciate that very much, because for some reason your connection is very, very bad. So in the interest of time, I'm going to go through the CMS updates, and then we can go back to Jean's other comments in chat, if she can put them in there. Next slide, please. Okay, so RTI annual interviews. As you guys know, the reviewers that evaluate the program overall do phone interviews. They do phone interviews and in-person interviews every year, and they are currently doing phone interviews in all of the facilities in Colorado and in Nevada. And Abby and Cleo are the two people that are calling your facilities and trying to set up times to meet with you, okay? So if you've heard from one of them, please feel free at your earliest convenience to respond to them and set up a time to do the phone interviews. We appreciate your support in this, and they appreciate your feedback as it helps inform the overall final report. And it is really, really important that we get the frontline feedback from our facilities on how they feel about it. They're going to be doing in-person interviews in April. That's all going to be in Northern Nevada, and I sent that out in the email, the weekly email update of the facilities that are going, which I had on my notes, but I think they walked away. So I will be emailing those facilities directly to share with you guys who is being interviewed and what days. I'm able to pull it up, so I'm going to share with you right now. So it's Carson Nursing, Life Care Center of Reno, Lakeside Health and Wellness, and Rosewood Rehab. on April 28th and April 29th, and you guys will be getting phone calls soon if you haven't already to set up times to meet with the RTI folks in person at the end of April. Also at the end of April, we will be having our annual on-site meeting with all of the other ECCPs across the country that are doing the Nursing Facility Initiative program like you are, in states such as New York and Indiana and Missouri and Pittsburgh, obviously, and Alabama. And we will be talking about what's coming next, which is the official end of ATOP2. So we've had lots of conversations. CMS has kind of been saying maybe they would do an extension of ATOP, perhaps they would do an add-on program, that there might be a bridge to a new phase, a direct contracting nursing home model phase. We got email a few days ago, last week I think, that said they were officially going to end the program on September 30th, 2020, and none of those add-ons or extensions will be in place. So on September 30th, ATOP phase 2 is going to end as originally planned, which isn't a huge surprise. But we were a little disappointed because we were hoping to continue this work in another way. That doesn't mean we're, Comagine Health is going anywhere. We still work with you all on the 12th scope of work from CMS. I've talked to all of you recently about what that work is going to look like. And then we've been recruiting all the nursing facilities in Nevada to participate in that work. It does mean that ATOP and the clinical staff that are in your facilities will no longer be in your facilities when the program ends at this point in time, at least under the ATOP2 overall program structure. We fully appreciate that you have loved having them in your facilities, and we have loved having them in your facilities as well, and they have loved being there. But now that the program's ending, we're going to be creating an exit plan and talking about what that next stage is going to look like. We don't have a lot of details, not surprisingly, from CMS about when will the codes end, how will people, what day can they bill until, how will they ask questions, how will you do wrap up. We think we're going to get a lot of those answers on April 21st and 22nd when we go to the on-site meeting in Pittsburgh. Until then, we will share with you information as it comes to us. And when we meet again for the Champion Forum on May 21st, we'll be able to share all of those exit details and answer a lot more questions about what's going to come next. What happens next in terms of continuing the last 7 months of the program and then phasing our presence out in the facilities is going to be a structured plan that the team and I will be working on together over the next several months, and that we will also be sharing with you at the May 21st Nursing Facility Champion Forum. So we'll be inviting a lot more people at your facilities to that event so that they have an opportunity to come and hear what that's going to look like as well. Next slide, please. What we're going to focus on are all of the things that we've been focusing on over the last 8 years. ATOP sustainability means continued Interact tool use, use of SBARs and structured tools to improve communication, early identification and treatment of changes in conditions, which you guys have made huge strides in, detailed nursing documentation, daily nursing documentation of CICs, timely in-person assessments by your practitioners, and then QI tool analysis of your hospital transfers that weren't avoided to see if we can learn anything and help you improve any processes at your facilities in order to keep people out of the hospital when there is an opportunity to do so. We're going to continue to focus on all of these things in the last 7 months. We're not going anywhere before September 30th. We also want to make sure that you take advantage of billing your billable CICs from now until the end of the program. There is no reason you cannot continue as you have and earn as many dollars for all of the hard work that you're doing, and that's what we want you to focus on, is to continue to work with us to make sure that these 5 bullet points on the screen are really running incredibly smoothly at your facilities by the time we end the program, and that you're able to take advantage of all of the dollars offered through the program right up until it ends. And we're going to be there to support you through that. As of right now, we do not have any indication that the payment reform G codes will continue after September 30th. We asked that on a call on Wednesday, yesterday, and we were told at this time there is no plan to continue the G codes after that date. There is still some talk about a direct contracting nursing home model, but right now they have no plans to do that anytime in the near future, which doesn't allow us to bridge this program into a new program by the time it would end. I know it's not what any of us want to hear, but it's what we're focused on are the positive outcomes that we can still contribute to over these next 7 months and ensure that you guys take advantage of the program to its fullest capability. Next slide, please. As a company, overall, we've been talking to you about a lot of different ideas that we've had about how we can continue our work in long-term care facilities for your long-term care residents. I mentioned the 12th scope of work, which we're already working on, and we're recruiting your facilities, and most of you have already joined that partnership, which we are very thankful for. We are still working on a concept to improve palliative care and quality of life, expand the use of and knowledge of palliative care services, the full scope in the state of Nevada within long-term care settings. And we're also working on a concept to improve behavioral health care in the long-term care settings as well. And then there's some opportunity and discussion around care transition and case management work that we're having at a higher corporate level. They're working pretty closely on trying to see if this is a business line service model that CoMagin Health would go into. And so we are looking at that, and we will probably come back to you with questions to see if it's something that you guys would be interested in participating in the future. I think there's going to be lots more information as time rolls out. We remain committed to improving health and the healthcare system in our communities, but especially in long-term care. It's a passion of all of the ATOP folks on the phone, including myself, and we are devoted to continuing our work with you and intend to do so. It's just going to come in a different package and perhaps a different time period. But in the meantime, please feel free to reach out with questions and share with us any comments or concerns that you have, and we will work very closely with you to end the program on an incredibly positive note as it comes to a close at the end of September. Oh, okay, so any questions about that right off the bat? I will be sending an email out to all of the nursing facility leadership, your administrators and DONs, for those of you that are champions and not in one of those roles and are not on the phone today. An email will be going out tomorrow making this announcement that it is going to end on September 30th and the steps that we're going to take in the near future. I will go back to Jean's comment about the case. If nobody else has a comment or a question about the information I just shared, feel free to take yourselves off mute if you have one. Okay, so quickly, Jean's last comment was the nephrologist needs to change the dialysis orders. He is being overloaded, HF, or too dry chest pain. I can't comment on that. Someone else needs to. I have no idea. You nurses know. Sam, I think you're trying to comment, but we can't hear you. Okay, we are 1 minute away from 2 o'clock. If there are no other questions, next slide, please, or comments, you know how to get to us. Here's all my contact info, Christina's contact info. Some of you are sitting with your ATOP nurses in a room watching this presentation right now. Feel free to ask them questions. If we don't have answers, we'll get you answers. Don't hesitate to reach out in the meantime so that we can provide you with as much support as possible through the end of ATOP. Thank you guys very much for your time. We appreciate it. and have a wonderful rest of the day.